Well, good morning. I would like to present my PhD topic, which is about conservative therapeutic possibilities for temporomandibular disorders. My name is Kata Kelemen, and I'm a prosthodontic specialist at the Department of Prosthodontics. And my vision is to establish a TMD protocol that is available for all the patients, apart from the localization of the dental offices, and also to make an emphasis on prevention and therapy as well by a multidisciplinary team, and to have a proper funding to increase the level of evidence. Here you can see my two specific goals, and my first topic is investigating the efficacy of combined therapy to physiotherapy in adults who have myogenic temporomandibular disorders. TMD is the third most common stomatological disorder, and up to 15% of the population has this kind of disorder. The most common type is the muscle disorder group, and its therapy we can use whether an occlusal splint therapy or physiotherapy as well, and the unmet need is to find a pain relieving method. And our aim was to investigate which reversible and conservative therapy offers the best results in the decrease of the symptomology. We phrased our clinical question as, is there a difference in efficacy of additional occlusal splint therapy to physiotherapy in adults who have myogenic temporomandibular disorders? And we hypothesized that the additional occlusal splint therapy is more efficient. Here you can see my systematic search. We conducted it in 4 databases. And after the selection, I have found 7 articles that were eligible for the full text. Here you can see my first outcome, which is comparing pain perception on a visual analog scale at baseline and at the 1 month follow-up as well. 5 articles were included, and the population heterogeneity was quite big. At the last article, it was an outlier because the patients could take some painkillers as well, so that's why it could influence our results. And both the results are mathematically and clinically significant as well. And both the results show that we can see a decrease at the pain perception in both groups. But despite the fact that it was a decrease, we can see only a small difference between the 2 groups. So that's why we can questioning the usage of the splint therapy. My second outcome was the maximum mouth opening at the baseline and at the 4 weeks follow-ups. Only 2 articles were included, and here the heterogeneity was quite big as well. And despite the fact that there was no mathematically significant result, both the results are clinically relevant as well. As a summary, all the included articles were randomized control trials, and the exclusion criteria was quite homogeneous. It means that no general diseases were included, and all the articles were using the diagnostic criteria for the temporomandibular disorders. There was a long-term follow-up as well, and in all the articles they were using the Michigan splint. My article has some limitations as well. Only 7 articles were included, and there was a heterogeneity in the population as well. And there was a physiotherapy group, so all the manual exercises and the counseling can be conducted under different settings, and this outcome mainly depends on the patient's motivations. As a conclusion, we could see a small mean difference change between the intervention and the control group as well. So that's why we could questioning the usage of the additional splint therapy in myogenic temporomandibular disorders. And also we have to make a bigger emphasis on physiotherapy. So a multidisciplinary team is required. But to distinguish all the results, more randomized control trials should be implemented in this field. We have some implications for practice. We should reconsider the usage of the splint therapy as the first non-invasive therapy in myogenic temporomandibular disorders. We should involve a multidisciplinary team, and also we should involve more physiotherapists in the field. The implication for research is that we should conduct more investigations on the splint therapy and on pharmacotherapy as well. And also we should restrict the inclusion criteria, like psychosocial conditions can affect the outcomes as well. And also it's required to make a subgroup analysis based on the TMD classifications. And for better results, we need some long-term follow-ups as well. Right now, my article is in revision at the Journal of Prosthodontic Research. And my second topic is investigating the efficacy of different medical devices in the treatment of temporomandibular disorders. And we would like to include the Wilks classification. This is also a systematic review and network meta-analysis. As its background, up to 16% of the population has this kind of disorder, and we would like to investigate arthrocentesis, which is an intermediate place between the medical and the surgical forms of the treatment. Its advantage that it can be done under local anesthesia, and we can use different medical devices like Ringer solution, hyaluronic acid, PRP, and steroids as well. And there was a network meta-analysis in 2019 with all these medical devices. So we would like to add glucosamine and chondroitin sulfate as well. And our aim was to investigate the efficacy of these medical devices. We phrased our clinical question. Is there a difference in efficacy of these medical devices in the management of temporomandibular disorders based on the Wilks classification? I have done my systematic search, and after the selection, we have found 22 articles for the full text. Oxo made classifications based on the TMD symptomology, and it has three main symptoms. The first one is the movement restriction, which can be either in maximum mouth opening or in protrusion as well. And as this is an objective outcome, this can be measured whether with a ruler or a caliper. We are saying that it would be our primary outcome. And the second one is the pain perception, which was measured on a visual analog scale. And as it's subjective, it would be our secondary outcome. And the third one is the sound effects, which is also measured on a visual analog scale. This is also a secondary outcome. In our article, we could find short-term and long-term follow-ups as well. But because of the short time, I would like to introduce you only my 3 months and the 12 months results. The first outcome was the maximum mouth opening at the 3 months. Here you can see that 4 interventions were included. And on the right upper corner, you can see the Sukra diagram, which shows that the higher the Sukra value, the bigger the likelihood that the therapy is on the top ranking. And according to this rank, we can say that the saline PRP and saline hyaluronic acid combination shows the best results. Both of them are clinically and mathematically significant as well. Going towards to our 1-year follow-up, here you can see also 4 interventions. And despite the fact that we cannot show any significant data mathematically, but we can see some relevant data with the saline and PRP combination in the therapy. As a secondary outcome, we can see the pain perception at 3 months. And according to the Sukra diagram, we can say that the saline and PRP combination shows both mathematically and clinically results as well. And at the 1-year follow-up, we can see that the tendency is also there. As the strength of this work is that it includes all the medical devices that are used in the arthrogenic temporomandibular disorders, all the included RCTs, and some long-term follow-ups are also included in this manuscript. You can see a direct and indirect network between all the treatment possibilities. And as our results, we can see some statistically and clinically results as well. Also, it has some limitations. For example, in some articles, they were using additional splint that can bias our results. And there were different types of hyaluronic acids as well. But unfortunately, we could not do any subgroup analysis based on the weight of the hyaluronic acid. As a conclusion, all the mentioned medical devices can be used for the management of orthogenic TMD, and the best results are with the saline and PRP combination. The implication for practice is that we should reconsider the usage of a single saline injection, and as we can see in some articles, they were using the additional splint therapy. We can also consider this combined therapy. And the implication for research is that we should conduct more investigations on the chondroitin sulfate and glucosamine as well, and some more follow-up periods are also required. Right now I'm doing the manuscript writing, and I'm at the result phase. And I would like to thank you for your kind attention with the quote, "If the plan does not work, change the strategy, but never the goal."
Thank you very much, Kata, for your presentation. I have a question regarding your second topic. So in the first one, we investigate myogenic temporomandibular disorder, right? And in the second, is this all types of temporomandibular disorders or also one specific type? And if it's all, how did we combat this issue in regards of heterogeneity? And then did all of the treatments were equally good for the different types of temporomandibular disorder?
Thank you, Alex, for your question. In my first topic, I was investigating only the myogenic one, but in the second topic, I was investigating the orthogenic type of temporomandibular disorders, and that's why we were using the VX stage, especially from 2 to 5, because the VX one is the myogenic one, so that's why we wanted to exclude.
Thank you so much. It was really nice. I just wanted to ask that in the first project, there was a great decrease by the utilization of combined therapy with non-steroidal anti-inflammatory drugs. Have you met with other studies that were definitely used non-steroidal anti-inflammatory drugs, whether they are good therapies? So this is the topic, technically.
Thank you, Danesh. Well, yes, I have already found many articles that were concerning about the non-steroidal anti-inflammatory drugs, but they say that it has some disadvantages, like adverse events like the gastrointestinal and hepatic, and also some renal problems as well. So that's why we should always take into consideration the patient's general health.
Yeah, I just wonder, in your second study, that are there any investigations on actually combining PRP with steroids? Because that would make sense to me. I mean that one is actually at the hormonal level and the other one is at the physical level, I would say. Same applies for hyaluronic acid.
Thank you. From the 22 articles that were included, only one article was concerning about these medical devices, and it was a 3-armed randomized control trials, and the one arm was the saline steroid, and the saline and PRP.